So, continuing our discussion about the asthma therapy class, in this video we will talk about the muscarinic receptor antagonists, and we will cover topics including the classification of these medications, their mechanism of action, their pharmacokinetics, and therapeutic uses and their adverse effects. So, the muscarinic receptor antagonists are classified as bronchodilators, same as with the beta-2 adrenergic agonists and same as with the methylxanthines. And the muscarinic receptor antagonist that is used in asthma is the Ipratropium. So regarding their mechanism of action, the muscarinic receptor antagonists, which is the inhaled Ipratropium, work by competitively blocking the muscarinic M3 receptors in the airway smooth muscles, leading to indirect bronchodilation through unopposed beta-2 adrenergic action. So normally in the airway smooth muscles, we have a balance between the beta-2 receptors action and the M3 receptors action. The beta-2 work to bronchodilate, so dilation, and the M3 receptors work to bronchoconstrict, so bronchoconstriction. Now, if we block the M3 receptors, the balance is more now towards the beta-2, so their action increases and there would be bronchodilation. Now, the Ipratropium also work to decrease the bronchial secretions. Now, the Ipratropium also blocks the M2 muscarinic receptors, and the M2 receptors function as feedback regulators, inhibiting the acetylcholine release. And feedback regulators means that when there is higher levels of acetylcholine, those receptors would get activated and would send a negative feedback that lead to inhibition of acetylcholine release. So these receptors work to decrease acetylcholine, and Ipratropium blocks them. So once they are inhibited, there is increase in acetylcholine release and reduction in extent and duration of Ipratropium blockage on the M3 receptors. And this ultimately may lead to paradoxical bronchoconstriction, because sometimes once the feedback regulator is inhibited, there is a lot of acetylcholine that would end up in bronchoconstriction instead of bronchodilation. And that is why the Ipratropium is contraindicated to be given alone. It has to be combined with beta-2 agonist. And the Ipratropium is not sufficient alone for asthma treatment anyways, even without the paradoxical bronchoconstriction. So it is always combined with beta-2 agonists to get the synergistic effect. Now here are some important points about the pharmacokinetics. So the available formulations of Ipratropium include nasal spray and metered dose inhaler and nebulized solution. And the duration of action of the inhaled Ipratropium is around 4 hours. Now let's talk about the therapeutic uses of the Ipratropium. So it is used in asthma treatment. So according to the GINA guidelines, the Ipratropium is used in acute severe asthma, particularly if the patient is having altered mental status or silent chest. So especially in severe attacks. And the Ipratropium is given with short-acting beta agonists, SABA, oxygen, and systemic steroids. The Ipratropium is also used in COPD. So according to the GOLD guidelines, the short-acting beta agonist is combined or not combined with Ipratropium is the initial bronchodilator for acute treatment of COPD exacerbation, along with supportive measures. Now let's talk about the adverse effects of the inhaled Ipratropium. So it may lead to paradoxical bronchospasm, as we mentioned, and it may lead to dry mouth, which is due to the anti-muscarinic effect of the medication. It also may lead to skin flushing, nausea, dyspnea, dizziness, sinusitis, bronchitis, and tachycardia or arrhythmia, also because of the anti-muscarinic action, and difficulty urinating and urinary retention. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe. And this video is a part of the Therapy for Asthma Masterclass. You can check it out. Link will be in the description of this video.